Welcome everybody. We are still waiting for a few attendees to join, and hopefully we will be able to start our session soon. We will be starting now, and let me introduce myself. I am Dr. Hussain. I am the consultant psychiatrist. I am also the master trainer for mhGAP and international coordinator for mhGAP in Kashmir. Today's presentation will be about the work of mhGAP team in Kashmir. I'm going to break my presentation into two parts. The first part will include the presentation that I made to the President of the Royal College, Professor James U. Bailey, when I initially requested help from the college. And the second same presentation was presented to the International Advisory Committee when we needed to seek the approval for the signing of the Memorandum of Understanding between the Royal College of Psychiatry London and Health and Medical Education Department of Jammu and Kashmir. I hope you are able to see the screen. The photograph on the screen is of a famous river that passes through Srinagar and then goes to Pakistan, called River Jhelum. You can see on the side of the river there are boats in which people basically live. I'm going to briefly describe, if you can see on the slide, the background of the psychiatric disease hospital in Srinagar, Kashmir. It is a 150-bedded hospital and is the only hospital for mental health in the whole of the valley. It is the main referral institution for all the patients suffering from any mental illness. It provides to and fro referral services with other associated hospitals or Government Medical College Srinagar. The hospital provides teaching program for both postgraduate and undergraduate students of the Government Medical College Srinagar and also provides a rotatory training program to the medical interns who are affiliated with it. Now I'm going to explain the district mental health program, which basically is the flagship of mental health intervention in the community. It was launched in 1996 and 97, and it was plan was to cover 123 districts in the ninth year plan. Its primary aim was that it was going to envisage a decentralized community-based approach to the problem, including training of the mental health team at the identified nodal institutes within the state, increasing awareness about mental health problems and effective health seeking patterns, Adequate provision of services for early detection and treatment of mental illness in the community itself, with both outdoor, and indoor treatment and appropriate referral measures, collecting data and experience for future planning, research, and improving service provision. These are some of the dates about the launching of the district mental health program in India. This slide shows the various reports about the World Health by the World Health Organization. If you see, it's a World Health report. It focuses on mental health. World Health Survey. Then District Mental Health Program 123, District 2007-2008. The important event is 2012 when WHO Executive Board adopts a resolution proposed by India, US, Switzerland to deal with the mental health problems and social sector. This is the photograph of the famous Dal Lake. These photographs are taken by my colleague Dr. Basharat, who is a consultant medicine in states. Although the district mental health program was launched, there were certain limitations to the services that it could provide. That treatment get in universal access to mental health services. Gaps are even larger with regards to preventive, promotive mental health problems as well as rehabilitation services. We are too slow in realizing the basic human rights of the people with mental illness. There is lack of technical support, including a range of inputs from establishing a mental health information system to human resource planning and implementing clinical management protocols. There is non-availability and amendment of guidelines without consultation or guidance. Regular consultation and learning from the first also did not take place. There is absence of uniform guidelines and technical support, and the objective of the program were interpreted differently in different states. For example, the integration into the primary healthcare and the desirability of the specialty facilities at the satellite outpatient clinics were interpreted by district mental health program districts in different ways. And in most places, it was just reduced to specialist-enabled outreach clinics rather than the primary care-based delivery of the mental health services supported by the specialist. There was clearly a lack of clarity about the goals of the district mental health program, and one of the reviews found that 85% of the health personnel stated that spreading awareness was the main purpose, following by integration of mental health and genital health services was the second most important purpose. Psychiatrists and clinical psychologists stated that the main purpose of district mental program was capacity building of the health system for mental health service delivery. I think this is a quite important slide. There is basically a poor coordination at the ministerial level. You see, the responsibility of rehabilitation is the responsibility of Ministry of Social Justice and Empowerment, while mental health is the responsibility of Minister of Health. Many people with mental illness, especially those with chronic mental illness, require a combination of medical treatment and rehabilitation to facilitate recovery. The lack of seamless service provision of health and rehabilitation services can be partly attributed to this separation of responsibility towards health and rehabilitation and the lack of intersectoral coordination in the delivery of these services. There is also a lack of coordination at the state level. The Department of Psychiatry in Medical College come under the Directorate of Medical Education, while the primary healthcare centers are under the Directorate of Health Services or Director of Public Health in most states. In many states, the lack of coordination between these two directorates impacted negatively on the implementation of district mental health program. And this is one of the important components that we will be focusing on the mental health gap program so that there is better coordination between the primary and the secondary care services. Coordination difficulties at district level. There is lack of uniformity in the nodal officer for coordination of the district mental health program in some districts. So we are not too sure who the nodal officer is and what his responsibility is. Since there are two separate departments, Head of Department of Psychiatry is the nodal officer at some places, the principal of the medical college or the secretary of the Department of Health and Family Welfare is at some other places. Teaching centers, they have limited public health perspective and little experience or incentive to work in the primary care settings. And they did not accept the core idea of integration of mental health with primary health care. I think this is a problem that continues to be faced in the mhGAP training program that we are conducting across the globe. There is deficit of simple treatment guidelines used by the health workers, identification and management of the mental illness. That's was the reason we specifically focused on mental health gap intervention guide formulated by WHO to overcome this deficiency. There is no technical support group to prepare and deliver such guideline. Lack of focus on the rights of the person and lack of sensitization of staff to avoid rights violation. There is poor information base, no information attendance and clinical and functional outcome, absence of state and monitoring system, no essential and periodic review, no scope of innovation, no information or outcome of treatment. Basically, there is no monitoring of the effectiveness of any training program or any strategy that has been implemented, which I think we focus specifically in the mhGAP training program that we did in District Gandharbal. There is inadequate human resources, there is lack of appropriate and trained human resources, rigid recruitment criteria for specialists, and lack of involvement of the non-specialist. This second component is the one which we will be specifically focusing in our mhGAP training program. There was lack of training for nodal officers, program officers, psychiatrists in the implementation of the program. So that was what was stressed on to train the trainers in the mental health gap training program to overcome this deficiency so they are clear about the role of the primary and secondary services in the implementation of mental health gap program. There are issues about the content of the training with health personnel wanting to be done in simple language, using case studies, increasing frequency, need for refresher course. That's what we will be focusing on the mental health gap. Lack of training for professionals at a primary health level like community workers, which will be focusing again in the mental health gap. Absence of training of social workers and their role. Training focused on hard skills with little emphasis of soft skills, personal development and leadership skills. So service delivery just revolved around the medical officer or the psychiatrist, negating the role of other professionals, community leaders and non-specialist force, and the role of the doctor was just limited to repeat prescription or referral to the specialist. This unit-dimensional approach on an isolated medical model focused on symptom reduction with medicine and not on recovery using a holistic biopsychosocial approach. This was one of the major issues that we are facing is the non-availability of drugs and that this prescription of drugs not based on any scientific rationale. Drugs budget become exhaustive because of the purchasing of expensive drugs. There is no availability of psychosocial treatment, and the psychologist social workers were largely utilized for administrative work and little time for intervention with the clients of the program. It was also not oriented to a continuing ongoing model which includes follow-up and engaging of the patients, and there was clear failure of the process of care delivery rather than the concept of public health. Lack of continuity of care or lack of support in the community has led to extensive stay of patients in the psychiatric disease hospital when they could be discharged in the community with support in the community, and patients who are discharged have a relapse or a loss to follow up. Developmental centers, employment center, counseling center, they are non-existent at least due to lack of trained human resource for these tasks. There was no near total absence of users and caregivers in the design, implementation, and monitoring of the program, and no provision for users and caregivers to question the health system on the staff when they were not available. There was no availability of the care. Poor involvement of NGOs and private sector, absence of organized approach to engage with civil society, bid of stakeholders' participation failed with several dynamic players wanting to play a role but not being offered opportunity. There was a presence of is the presence of private sector, but no mechanism for coordination for delivery of services. There is inadequate provision of secondary or specialist services, especially for the old age and child and adolescent. They are missing and they need to be developed. Some school counseling services are being provided by the Ministry of Human Resources and Development, and older people were notable for their absence. The lack of crisis team in the community, ambulatory services, daycare, and mental health first aid, they were non-existent in the program. This is an email that I received for Professor Vikram Patel, who is the Professor of International Health Medicine, Senior Research Fellow Goa. He is an advisor to WHO Expert Advisory Group, member of Economic Forum, Global Forum, and also member of the Mental Health Policy Group for the Government of India. I'm just going to read this paragraph that's part of the mail. It was basically sent how to evaluate the training, what we need to focus on once the training is complete, and stress the role of focusing on competencies rather than knowledge and attitude, which is a weak predictor of the impact of the outcome of the training. And will I just like to read the last paragraph, last line, that one of the major reasons for using local expert centers is to also use the training as an opportunity to develop collaborative relationship between the primary and specialist care, a key requirement for the successful integration of mental health in primary care. So these were some of the recommendations that were formulated and submitted. One was the need to evolve the collaborative arrangement with strong community participation, linking with voluntary sector and civil society initiatives with academic institutions from interdisciplinary background, and to utilize the private sector knowledge and skill-based educate safeguard against commercial interests prevailing over public interest. Now, this was the recommendation we submitted to the Royal College and how the Royal College could help. It could help with developing the curriculum of the mental health for primary care workers. Here we are using the mhGAP guide formulated by the WHO, which Royal College is using in training across the world. Curricular development in addition to mhGAP on mental health for non-specialist, specialist and non-specialist workers. Curriculum development for teachers, police, and other stakeholders. Implementation of curriculum through teaching both specialist and non-specialist workforce, which we will focusing basically in the current mhGAP training program. Focusing on development various employment projects, residential services, other outreach services. intersectoral work and liaison with primary care services. These are a few other things that we think that college might get involved. If possible, we can seek the help of the college in contributing or effectively implementing the aims and objectives. We are grateful to the support and advice received from the Iraqi subcommittee and also support from the Special Interest Voluntary International Psychiatry Group, which recruited and was able to send volunteers for training to Kashmir, which led to the successful completion of mhGAP training in Kashmir. Now that was about the background of the problem that we are facing and which we needed to overcome when we are going to implement the mhGAP training program.